Welcome to the deep dive. Today we're tackling something, well, truly unsettling. Insulin. A drug we usually associate with healing, with sustaining life, being deliberately used as a murder weapon.
It's a chilling thought, really.
It is how something meant to cure can be twisted into this virtually untraceable tool for harm.
It's deeply disturbing. And what makes it particularly insidious is, how counterintuitive it all is. Insulin is so essential for so many people.
Right.
Yet its misuse can be fatal, and the way the body responds can, well, easily mask any malicious intent.
Exactly. So our mission in this deep dive is to really unpack the complexities around these insulin killings.
Yeah, get into the details.
We'll explore why they're so incredibly difficult to detect, the innovative methods that can bring them to light, and why this seemingly rare crime should, frankly, concern us all. Have you ever stopped to consider how something with such a positive purpose could be weaponized so effectively, often leaving like no immediate trace?
It really makes you think.
So let's get right into why insulin is such a, well, silent killer.
Okay, so the first critical point to grasp is just the nature of insulin itself in the body, specifically in someone who isn't diabetic.
Right.
It's metabolized remarkably quickly,
So it breaks down.
very fast.
Yeah.
This rapid breakdown means that after a fatal overdose, the substance itself basically disappears from the bloodstream relatively quickly.
Okay, so it doesn't linger like, arsenic or some other poisons might.
Not at all. And because insulin's main job is to lower blood sugar, the immediate, obvious consequence, hypoglycemia, well, that can arise from lots of natural causes.
Ah, okay. So it's understandable then that doctors, pathologists, they might not initially suspect homicide when they see a case of, just unexplained low blood sugar.
That's a crucial hurdle right there. Unless there's a specific reason to be suspicious.
Yeah.
The possibility of deliberate insulin overdose might not even cross their minds in the initial investigation. There's a forensic pathologist, Dr. Paul Uribe, who has a lot of experience with these cases. He put it very bluntly.
What did he write?
He said, "You're not going to stumble across an insulin homicide. You have to have a suspect and you have to look for it. Because if you're not looking for it, you're not going to find it."
Wow. That really underscores the challenge.
It does. The key insight is that suspicion, a targeted suspicion, is often the absolute crucial first step.
You have to look for it. It's not just going to present itself.
Precisely.
That highlights this need for a proactive approach, maybe a certain level of suspicion, as you said. Which brings us to the next point, right? Awareness and protocols in the medical community.
Yeah, and it seems like there's some pretty significant gaps there.
How so?
Well, what's quite revealing is the apparent absence of standardized procedures for ER doctors and pathologists when they are faced with severe unexplained hypoglycemia.
So no checklist like, could this be insulin?
Not universally, it seems. Our sources point out West Virginia is actually the only state mentioned as having pursued legislation specifically trying to address this.
Yes, I saw that. The bill named after Michael Cochran, who was a victim himself,
That's the one.
it aims to mandate insulin testing in ERs for patients who come in with symptoms that might suggest poisoning.
It appears to be a direct response to the agonizingly slow process his family went through trying to get answers.
I can only imagine.
But, this kind of legislative action isn't always welcomed by the medical community.
Right, there's often pushback.
Exactly.
Yeah.
The American Academy of Emergency Medicine, for instance, they oppose mandates like that. They argue against what they call legislating medical care.
Okay, so what's their alternative?
They advocate for continuing medical education. Their stance, which Jonathan Jones articulated, is basically that well-trained doctors are best placed to make these decisions, and that education is more flexible and effective in the long run than rigid laws.
It's that classic tension, isn't it? Mandates versus professional judgment and education.
It really is. And then, on the other hand, you have the National Association of Medical Examiners. They emphasize something different but equally important.
Which is?
They stress the need for, and I'm quoting here, unobstructed access to scene information, witness statements, and medical records for really thorough death investigations.
So context is key for them. It's not just the lab results.
Precisely. The medical examiners are saying the medical findings alone often aren't enough. You need the whole picture. The circumstances, what witnesses saw, any odd events that might point towards foul play, especially when the standard blood tests aren't conclusive.
That makes sense. So given these challenges and just spotting it initially, let's get into the forensic hurdles and maybe the innovations trying to overcome them.
Yeah, this is where it gets really interesting, forensically speaking.
Because, as we've said, traditional toxicology often just comes up short. Insulin breaks down too fast.
Right.
So what can investigators actually do to detect it after death?
Well, one key method is something called the C-peptide test.
C-peptide. Explain that.
Okay, so C-peptide is a substance the body releases alongside its own insulin when it produces it naturally.
Ah, okay. A byproduct.
Exactly. So by measuring C-peptide levels, investigators can get an idea how much insulin the body was making itself versus how much might have been, injected from outside.
Makes sense. But there's a catch, right?
A big one. And Dr. Uribe really emphasized this. The test has to be done before any glucose is given to the patient to treat the low blood sugar,
Why is that?
because giving glucose immediately triggers the body to release its own insulin and
Yeah.
C-peptide.
Ah, so it messes up the measurement?
Hmm.
It clouds the picture of whether external insulin was there beforehand?
It completely throws it off, as Dr. Uri put it. And another issue is that smaller hospitals might not even have the C-peptide test readily available.
So it's a race against time, and you need the right tools available immediately. Test before treatment.
That's the critical window.
Yeah.
It really highlights the need for both awareness and having these specific diagnostic tools on hand.
Okay. So C-peptide has limitations. What else is emerging? What other techniques?
Well, beyond C-peptide, there are some promising forensic techniques being developed. One is injection site analysis.
Injection site. How does that work? How can you find evidence of a shot after time has passed?
It sounds tricky, but even though insulin breaks down fast systemically, like in the blood,
Yeah.
it can actually linger for a bit longer, right, in the tissue where it was injected.
Really? Locally?
Exactly. So during a post-mortem, forensic pathologists can carefully take tissue samples from potential injection sites, maybe an arm, abdomen, wherever, and analyze them. Sometimes they can detect trace amounts of insulin there.
Wow.
Not
Has that actually been used successfully?
Yes, significantly. It was apparently pivotal in that West Virginia Veterans Hospital case we'll talk more about. Dr. Uribe said it provided definitive proof they had been injected with insulin, even for victims who weren't diabetic.
Definitive proof. That's huge. Even when it's gone from the blood.
It can be. It offers a potential way to find localized evidence even after systemic levels have dropped.
Okay, that's one major advancement. What's the other emerging method you mentioned?
The other one is vitreous fluid testing.
Vitreous fluid. That's the fluid inside the eyeball.
That's right. Research has shown that insulin might be detectable in post-mortem vitreous fluid.
Why there?
The thinking is that the eye is a somewhat isolated compartment, biochemically speaking.
Okay.
So it might preserve substances like insulin for longer than the general bloodstream, especially after death. This could be particularly valuable in non-diabetic victims who wouldn't normally have insulin in their system at all.
So finding it there would be a big red flag.
Potentially very significant. Dr. Uribe noted that finding insulin in the vitreous fluid of someone with no history of diabetes, no prior exposure, could legitimately tell you something crucial about the cause of death.
These techniques sound absolutely vital for uncovering these, well, incredibly subtle and dangerous crimes.
They really are pushing the boundaries of detection.
Now, our sources also mention specific red flags, things that might alert medical professionals earlier on. What are some of those key indicators?
Okay, the primary ones are pretty straightforward, at least on the surface. First, severely low blood sugar hypoglycemia, that is critically unexplained, especially in someone who isn't diabetic.
Right, the context matters. No history of diabetes.
Exactly. And another potential warning sign is unexplained low potassium levels. That's called hypokalemia. Excessive insulin can also cause that.
So it's about spotting inconsistencies, lab results that just don't fit the patient's known medical background.
It really boils down to recognizing patterns that are out of the ordinary for that specific patient.
Okay, so vigilance for things that don't add up. The sources then detail, too, very disturbing case examples that really bring home the challenges we've been talking about. Let's start with the West Virginia Veterans Hospital case.
Yeah, this was a truly tragic situation. A nursing assistant there, Rita Mays, ultimately admitted to killing 7 elderly patients using insulin injections.
7 patients? That's horrific.
It is. Now, it was particularly relevant to our discussion is how the investigation unfolded. It relied heavily on exhumations.
They had to exhume the bodies.
Yes, and then perform that injection site analysis we just discussed on tissue samples. That was crucial to confirm insulin was present in these non-diabetic individuals.
So that technique was put into practice there with significant results.
Absolutely. It powerfully demonstrates the real-world application and importance of that forensic method. Mays eventually confessed, but the forensic evidence was key.
Just devastating. And then there's the other case, Michael Cochran's. This one seems to highlight the systemic hurdles even more vividly.
The Michael Cochran case is, well, it's a stark and heartbreaking example of how easily an insulin homicide can be missed initially.
What happened there?
His wife, Natalie Cochran, who was actually a pharmacist.
A pharmacist, so she had access and knowledge.
Precisely. She used insulin to kill him. But the initial death certificate listed the cause as natural.
Natural causes. Despite him presumably having symptoms.
Despite him presenting at the hospital with severely low blood sugar and having no history of diabetes.
And his parents. They had to fight for answers for years, right?
6 years. A 6-year struggle for the truth. It's almost unimaginable. His mother, Donna Bolt, said something quite poignant about hoping others wouldn't have to wait for a result like we had to wait.
6 years. Just awful. What caused such a delay?
Several things. As mentioned, despite the low blood sugar and no diabetes history when he arrived at the hospital, an insulin test wasn't done.
Why not? Was it not standard?
It just wasn't performed then.
Yeah.
The series suspicions really ignited later when an investigator, Tim Bledsoe, found an insulin vial at their home.
Yeah, physical evidence.
Yes. And Natalie Cochran gave conflicting stories about why it was there, which obviously raised more red flags.
Okay, so suspicion is mounting. But the first autopsy?
The first autopsy came back undetermined. A major reason cited was the advanced state of decomposition.
Right, decomposition makes things much harder.
It does. And as the prosecutor, Tom Truman, explained, not having a medical examiner ruling it a homicide creates a big problem for building a criminal case. You lack that crucial medical certainty.
So even with suspicious circumstances, without that initial medical examiner ruling, the case stalled.
It seems so. Charges were even dropped at one point. This really highlights the critical importance of that initial death investigation, the timing, the thoroughness, the specific tests ordered. It seems unclear why a more targeted autopsy wasn't done immediately given the circumstances that emerged later.
So what finally broke the case open?
It wasn't until Dr. Uribe got involved. His expertise led to a second exhumation.
Another exhumation.
Yes. Now, by this point, they were dealing with skeletal remains, so injection site analysis wasn't possible.
So how could they determine it was insulin then?
Dr. Uribe looked at the whole picture. The documented, unexplained, severe hypoglycemia before death, the lack of any other medical explanation for it, and the surrounding circumstances. The insulin vial, the conflicting statements. Based on that totality of evidence, he ruled it an insulin homicide.
So circumstantial evidence combined with the unexplained medical facts.
Exactly. And critically, during the trial, an endocrinologist testified, confirming there was simply no other plausible medical reason for Mr. Cochran's blood sugar to be that dangerously low.
And Natalie Cochran.
She was ultimately convicted of first-degree murder.
What a chilling story. It really underscores the persistence needed and how vital expert knowledge is for these kinds of hidden crimes.
It truly does.
So as we wrap up this deep dive, let's try to synthesize. What are the key overarching takeaways about insulin homicides?
Well, I think it's clear that detecting these crimes presents this really complex web of challenges. You have the fundamental nature of insulin itself, how it disappears quickly in non-diabetics.
Right, the vanishing evidence.
Then there's the potential lack of widespread awareness and standardized protocols among both doctors and forensic teams.
The need for suspicion and specific procedures.
Exactly. And traditional post-mortem toxicology just often isn't up to the task.
But there's hope with the newer methods.
Yes, the emergence of these innovative techniques like injection site analysis and looking at vitreous fluid offers promising new avenues for detection and, ultimately, for justice.
And as those cases, especially the Cochran case, so tragically illustrate, there's a massive human cost when these crimes go undetected.
Absolutely. The Cochran family's 6-year ordeal is just a stark reminder of the devastating impact. It really hammers home the importance of, well, fostering suspicion when things don't add up, conducting targeted investigations, and constantly working to refine protocols for everyone involved, medical and forensic professionals alike.
Which leaves us, and you listening, with a final thought to consider. Given how relatively easy insulin can be to obtain, and these significant hurdles in detecting its misuse as a weapon, what broader implications does this have for how we understand crime, for the role medical professionals play in identifying it?
A tough balance.
It is. Think about that delicate balance between needing to trust medical explanations, but also maintaining vigilance for these less obvious, yet potentially lethal forms of harm. It's quite a sobering thought to carry forward.